Was about the nephrotic syndrome. Do you have any question up to this? Let's go to now patient number 4 and do a little more injury. Is that right? And see what happened. You already know our patient number 1, he had non-selective proteinuria, albuminuria. Next patient had non-selective proteinuria but less than nephrotic range. Third patient has heavy proteinuria of the nephrotic range. Let's come to the next patient. In this patient, suppose this is your circulatory system. This is his renal system. And this patient, patient number 4, let's suppose there is more severe injury, +4. It is so severe injury that inflammatory lesions, severe inflammatory lesions develop in glomeruli. Glomeruli become loaded with neutrophils, they become loaded with macrophages, and severe inflammatory lesions form in glomeruli. Yes, you have a question?
Yes, that's regarding the sub-nephrotic range. Why only low molecular proteins will be lost in the nephrotic range instead of non-selective?
No, this will be also non-selective.
Correct, but stage 2.
Secondly, listen. Actually, some nephrotic patients have only albumin loss, and some nephrotic patients have both losses. Right? It depends on. If damage is just increased number of pores, but not the size of the pores, you develop albuminuria. And if it is so many pores that total albumin loss is more than 3.5 grams, nephrotic will come. But another nephrotic in which not only increased number of pores is there, but there is increased size of pores. So he will develop non-selective proteinuria. Am I clear? So listen, this concept that selective proteinuria, it does not tell nephrotic will be there or not. Selective proteinuria only tells that there are some excessive small pores and albumin is coming. But if albumin is less than 3.5 grams, subnephrotic. If albumin in the urine is more than 3.5 grams, this is nephrotic. Now listen, another patient. He has few extra pores, but they are very large. So he has albumin and globulin. So we say non-selective proteinuria, but less than nephrotic. But the same pores become more. Non-selective proteinuria into nephrotic. Is that right? So nephrotic syndrome patient has just heavy proteinuria. It may be selective, it may be non-selective. Later on in the lecture I will tell you, when nephrotic syndrome is due to minimal change glomerulopathy, it is selective proteinuria. And when nephrotic syndrome is due to membranoproliferative disease, it becomes non-selective. Because in minimal change glomerulopathy, there are some cytokines which just neutralize the charges, negative charges. Pore size is not increased. So when all the glomerular basement membrane negative charge disappear, heavy albumin start leaking. Because that is no more repelled. Because normal size of the pore should allow the albumin. But normally albumin does not go down due to repulsion by the charges. So minimal chain disease pathology, just there are some cytokines and some biochemical substances which neutralize all the negative charges in 2.5 million glomerular basement membranes. And everywhere heavy albumin loses. But when I tell you another disease like focal segmental glomerulonephritis, I will teach you later, don't be confused. Or membranous glomerulopathy or membranoproliferative glomerulopathy, then big pores are formed. Not only pore number is increased, but size is also increased. So you will have nephrotic with non-selective proteinuria. Am I really clear to you people or teaching myself? You are understanding something? Okay. You are looking angry. You understand it? Okay. Now listen. No, some people after my lecture become angry. Most of them become happy. They become angry. They say, why we did not understand before? And I never ask, they are angry with whom? With themselves or with someone else? Anyway, let's come back. This is the next patient. Here I say, there are truly very severe injury to the glomerulus. There are severe inflammatory reactions going on in glomeruli. And even glomerular membrane somewhere having big holes. This time, of course, albumin will come down, isn't it? With that, globulin will also come down. Am I right? Every type of plasma protein is coming down. And with that, even RBCs will come down. Now picture will change. Now picture will change. It's a very critical point of understanding where we stand now. That there's really big damage and there are inflammatory lesions, big inflammatory lesions going on there. Lot of antibodies, maybe complements, lot of neutrophils, macrophages, platelets sticking there, lot of cellular element. Pathology is really advanced in this patient. So he has albuminuria with globulinuria or non-selective proteinuria. With that, he has hematuria. What this patient has developed? Hematuria. Especially in the urine, you will find whenever RBCs or blood in urine, we say there is hematuria. But every hematuria is not coming from glomeruli. Even if your urethra is damaged, you develop hematuria. If your urinary bladder is damaged, you develop hematuria. But this is the hematuria of glomerular region. This is one of the very dangerous hematuria. Because this tells there's something seriously wrong with your glomeruli. Now, how you really know that this particular hematuria is coming from the glomeruli? How you differentiate this hematuria from other hematurias? Very simple. Have you seen stars? I'm not talking about movie stars. Stars in the sky. They have pointed edges. Actually, any RBC which has to slip through this and come all the way down, do you think this RBC will have normal shape? It will have some star-shaped spikes. And these starry RBCs, when you find this type of RBCs into urine, we think they are coming from glomeruli. Is that right? So RBCs into urine, which have been pushed through squeezing and all dysmorphic RBCs, the morphology is disturbed. So you find RBCs which are like this. They are coming from where? All the way from glomeruli, and they squeezed their way through very much disrupted membrane. Secondly, when RBCs really leak in heavy number, they produce a traffic jam. And where they produce a traffic jam? Not on the roads, on the tubular system. So what really happens? If this is your tubule and RBCs get stuck on the way, and when these RBCs are stuck and they are being pushed, so these RBCs are compressed against each other and they are held together by some proteins. Some proteins holding the group of RBCs which are pushed by, first they accumulated, they produced a block here, then fluid accumulated and pushed it forward. When these RBCs group will come out, right, this RBCs will making microscopic cylindrical, microscopic cylinders. This cylinder is like the cast of inner lumen. So when these groups of RBCs appear into urine, we say patient is showing RBC cast. RBC cast is a dangerous thing. It means RBCs are coming from the top, glomeruli, and they have been heavy proteinuria and they have been stuck into what? Tubule, and then they have been pushed by the fluid and they become compressed and they make a cast of the lumen of the renal tubule, and we call them RBC cast. So patient is now developing not only albuminuria, globulinuria, he is developing hematuria with dysmorphic RBCs into urine and red cell cast. You heard of this term? Right. Do you think under these circumstances, when glomeruli are swollen and inflamed, lot of glomeruli are infiltrated with inflammatory cells, do you think blood can easily pass through glomeruli? No. Even injured endothelial cells may develop the platelet plugs. So total blood flow through kidney will become less or more? Less. Normally during inflammation, blood flow become more. But when glomeruli are severely inflamed, glomeruli swell up and they become loaded and clogged by the inflammatory cells. So blood cannot pass through that. So you will make more GFR or less GFR? Glomerular filtration will be more or less? Less. For when glomerular filtration start going down, now here the difference from nephrotic patient. The glomerular filtration in this patient is going down. So total urine formation will be normal or less? Less. And when urine formation per 24 hours is less than 400 ml, we say patient has oliguria. So these patient along with this thing develop oliguria due to reduced GFR. They develop oliguria. These things were not so severe in nephrotic patient. Things are getting worse. Total urine amount is less. And because, now here's a very important point, because the total filtration is less, so total loss of protein will be less than nephrotic. This is a very, very fine point to understand. Listen with your both here. Listen. Here, there was significant formation of filtration. So with filtration, a lot of proteins were filtered and coming down. Here, injury is more. So average student may think proteinuria should become more, but actually proteinuria become less. Why proteinuria is less? Because lesions are so advanced that total filtration is reduced. When total filtration is reduced, then total amount of filtered protein is also reduced. And so, in these patients, albuminuria and globulinuria is less than the nephrotic patients. Or, we can say another thing. Patient come to you with nephrotic syndrome. Unfortunately, his disease become advanced. So, patient who was only nephrotic, having generalized edema, heavy proteinuria, hypoproteinemia, gradually his edema start becoming less, hypoproteinemia become less, proteinuria become less. Maybe a simple doctor become very happy, and he is not looking for something dangerous start appearing into urine. RBCs and RBCs cast. So actually patient is getting better or worse? Worse. Patient is getting worse. You are intelligent. Patient is getting worse. You should be only happy when edema become less. You should be only happy when edema is reducing, when proteinuria is reducing, hypoproteinemia is less, and when dangerous things are not coming. Then this is the good news. But if all these nephrotic features are reducing and hematuria is developing, RBC casts are developing, dysmorphic RBCs are developing, oliguria is developing, and when GFR is less, do you think waste product from the blood will be removed properly? No. So urea and creatinine start accumulating in the blood. Urea and goes up and creatinine goes up. So blood biochemistry is now further disturbed. And in the blood, when urea and creatinine are rising, this biochemical disturbance of the blood is given a special name. What is that name? Azotemia. The term is called azotemia. So patients start developing, yes, azotemia. So look, just severe inflammation led to reduced GFR. Reduced GFR led to oliguria into urine, and less GFR reduces the capability of the kidney to eliminate the waste product, and patient develop azotemia. And of course, blood flow to kidney is really dangerously reduced. So renin mechanism is slightly increased or powerfully increased? Powerfully increased. So very powerful stimulation of renin, angiotensin, aldosterone axis. Not only salt and water is retained, but one of the most powerful vasoconstrictor is angiotensin 2. So patient develop hypertension. So patient is now developing hypertension. So do you think patient is getting better or worse? Worse. So now look at it. One patient who was nephrotic going to advanced stage. Initially he had heavy proteinuria, then hypoproteinemia and generalized edema. Unfortunately, underlying mechanism of injury became amplified. So inflammatory lesions develop in glomeruli. That reduces the glomerular flow. So protein losses become less, hypoproteinemia become less severe. Of course, then proteins level are better in the blood, generalized edema become less. But actually, a dangerous black triangle is appearing, a deadly triangle. What is that? Heavy damage to glomeruli. So patient is developing hematuria, especially RBCs, dysmorphic RBCs and RBC cast. With that, patient is developing oliguria with azotemia and patient develop hypertension. Now it is no more nephrotic. It is no more nephrotic. Now it is nephritic. What is this thing? Nephritic syndrome. So what concept we really made? That is the damage to glomeruli, we keep on changing the face. Is that right? That very little damage and you develop albuminuria. A little more damage, you develop albuminuria with globulinuria. So non-selective proteinuria. Heavy damage, you may develop heavy selective proteinuria or heavy non-selective proteinuria, eventually precipitating in the formation of nephrotic situation. Further inflammatory lesions leading to converting nephrotic into nephritic, or patients start directly as nephritic. And then the next patient may develop more aggressive injury. What will happen? We'll talk about after the break. Right. So in the previous lecture, we were discussing about that how different degree of and different type of injury to glomeruli can produce different type of clinical presentations. Right. We have discussed few clinical presentations and more I will discuss now. Let's recap a little bit that glomerular injury, the heading should be glomerular injury, right? Not one glomeruli, multiple glomeruli, of course. And you can say degree of injury +1. And what was there? Yes, you will tell me the mechanism that was leading to selective protein urea, or other name for selective protein urea was albumin urea. Then we said there was second more injury, and that was leading to, yes, non-selective protein urea, but it may be subnephrotic range, right? Then further damage, heavy protein urea, which may be selective or which may be non-selective, and this will eventually lead to nephrotic syndrome because its nephrotic range more than 3.5 grams per day. Wrong. Then we come to the next situation, and injury has become more severe and producing severe inflammatory lesions in glomeruli. So in this case, you have to always remember, here was a cold triangle, and this cold triangle was, a nephrotic cold triangle was heavy proteinuria with hypoproteinemia leading to generalized edema. With that, there were two things, hyperlipidemia and hyperlipiduria. Now, in very severe injury, this cold triangle will shrink and a hot triangle will form. And this hot triangle, which is more deadly situation, even though there may be some degree of proteinuria, there may be some degree of hypoproteinemia, there may be some degree of generalized edema, but the more dangerous things which will develop in nephritic syndrome, they are high blood pressure, hypertension, oliguria with azotemia, and of course hematuria with dysmorphic RBCs and RBC cast. Is that right? Now we go to the next situation. That let's suppose there is injury which is very, very intense. very intense injury, so severe injury it really made multiple big disruptions in glomerular basement membrane. Let's suppose injury was so severe that glomerular basement membrane had big disruptions. And there is severe inflammation of the vessels ruptured. Now, in this case, of course, it's easy to understand that albumin will come down, isn't it? Globulins will also come down, RBCs will also come down, RBC which are dysmorphic, and RBC cast will also come down, right? But actually, in this particular case, lot of fibrin lays down, fibrin molecules. And fibrin molecules are accumulated here. And breakdown product of fibrin molecule are very, very stimulating to the epithelial cells for the growth. Again, listen. If there is very, very severe disruptive injury, right, then a lot of fibrin come down and it breaks down into product which act as a growth product for epithelial cell. Plus, fibrin attract macrophages. So a lot of macrophages come from this area to this area. So local epithelial cells are proliferating. With that, a lot of macrophages are migrating to this area with very severe intense injury. And with that, of course, there are platelets there, other macrophages are there, mesangial cells are activated also with this injury, and all these cells producing a lot of growth factors. You're understanding? And this very concentrated growth factors present over here, all these epithelial cells will start proliferating, and within these proliferating epithelial cells there will be a lot of macrophages which are also proliferating, and within few weeks you will find that whole the urinary space is full of cells. Do you think now this urinary space can work well? Again, extremely severe injury, lot of growth factor, some coming from breakdown of the fibrin, some from platelet derived growth factor, some coming from the macrophages, some growth factor coming from mesangial cells, and under the influence of all these growth factors and other inflammatory cytokines, inflammatory products, there is a lot of migration of macrophages, monocytes from the vascular compartment to urinary space, plus local epithelial cells proliferate, and they make these cellular crescents. They make these cellular crescent. Some people call this situation crescent glomerulopathy or crescent glomerulonephritis. But we are talking about the clinical presentation, not histology. How this patient will come to you. This patient will not come to you with early situations, rather because his glomeruli are getting blocked with these crescents, he will develop progressive loss of kidney function. What they are developing? Rapidly progressive loss of kidney function. And in this patient, of course, all these things of nephritic are there. All the problems related with nephritic are there. But at the top, so much urea, creatinine and other products are accumulated in the blood that clinical features of renal failure become apparent. And previously, what happened that there were biochemical disturbance in the blood. In case of nephritic, you remember urea and creatinine was accumulating in the blood. So that was azotemia. Azotemia means that due to reduced renal function, azotemia means due to reduced renal function, or what is there? There is disturbed blood chemistry. But this situation is advanced. Blood chemistry is so much disturbed that signs and symptoms of renal failure appear. For example, potassium in the blood become very high and arrhythmias may start. Uremic pericarditis may develop. Uremic enteropathies may develop. Uremic, you can say, central nervous system features develop. Uremic frost may come on the skin. I want to know what is uremia. Yes. What is uremia? Yes, please. And look, all of you have heard the word uremia. So what is uremia? Don't tell me urine in blood. What is uremia? Nephrology. Very simple. When due to renal dysfunction, blood chemistry is so much disturbed, the signs and symptoms of failure appear. We say azotemia has been converted into uremia. So what is the difference in azotemia and uremia? The only thing is, as if I say this patient has only azotemia, no uremia, it means his blood chemistry is disturbed due to renal dysfunction, but not enough to produce signs and symptoms of renal failure. But when due to reduced renal function, blood chemistry is so much disturbed that patient develop multiple clinical features of renal failure, then that syndrome is called uremia. So this patient will develop uremia, or simply we say this patient will develop renal failure. He will develop renal failure, and this renal failure develop in a short time or very long time? In a short time, with heavy injury, very short time, kidney failed, rapidly progressive. Every week they are getting more and more advanced failure, right? So there are many names for this condition, right? They call it crescent glomerulonephritis or glomerulopathy, or some people call it rapidly progressive glomerulonephritis. The glomerulonephritis is becoming very rapidly progressive. But clinically, this patient will come with acute renal failure. So acute renal failure, because it is over the few days and weeks, kidney function fails significantly. So we say patient is suffering with acute renal failure. So how many phases of glomerular injury you know? Glomerular injury may produce selective proteinuria, or it may produce non-selective proteinuria. Even, I did not mention, sometimes few areas in glomeruli are injured, but big areas of injury. Patient may develop hematuria. So hematuria is also one feature of somewhere here, hematuria, that there is severe injury to glomeruli, but only few points. So patient may develop only hematuria. But if there are severe injury with a lot of points, patient will develop nephritic. Is that right? And if there's severe injury, very intense and very rapidly, patient's clinical situation deteriorate and patient develop the altered biochemistry of blood as well as clinical feature of renal failure, we say acute renal failure. Right? But underlying problem may be like this. And after that, the last end stage kidney. Anyone, listen now very carefully, anyone who has glomerular injury moderate to severe, but for long time, maybe patient with nephrotic, maybe patient with nephritic, or this may become prolonged. Any one of the injury, either it is moderate injury or it is severe injury, if it continues to glomeruli over the years, what will happen? When inflammatory cells and inflammation is there for very long time, then inflammatory cells start producing growth factors. Inflammatory cells start producing growth factors, especially for proliferation and activation of fibrocytes and fibroblasts. So regardless of whatever the original cause of injury, originally patient may develop nephrotic, or patient may develop nephritic, or patient may develop rapidly progressive situation, whatever he developed. If it is not controlled and it goes over the years, in all these patients who are becoming now chronic patients, there may be significant activation of fibrocytes and fibroblasts, and they start laying down the collagen in glomeruli, and glomeruli become collagenized. Do you think if they become fibrotic and collagenized, will they work? No. And do you think you can reverse their function? No. So this progressive, irreversible damage to glomeruli will eventually lead to chronic renal failure. So chronic renal failure is a waste basket in which any one of them may come. Chronic nephrotic may come into this. Chronic nephritic may come into this. This never resolved may come into this, right? So some patient may come to you just with the chronic renal failure, or we call it chronic glomerulonephritis. And when you do biopsy or when you study the kidney, you find that renal cortices are shrunken, renal glomeruli are fibrotic. Here you just find that all this is fibrotic and tubule is atrophied. Of course, nothing is passing through that, right? So glomeruli fibrotic. They don't use the word fibrotic. Nephrologists use the word that glomeruli are hyalinized. Hyalinized. Hyalinization of glomeruli. Right? So what really happens that anyone who is having injury to glomeruli, it may be mild or it may be moderate or it may be severe, but if it lasts for too long, then inflammatory cells start producing growth factors, and if those growth factors severely stimulate the fibrocytes and fibroblast process, then glomeruli are replaced by fibrotic points, right? And when glomeruli become fibrotic, their dependent nephron tubules become atrophied, and we say there is chronic renal failure. Am I clear? And any one of earlier situation can go into chronic renal failure. And sometimes some patient may come with chronic renal failure and you don't know what was the original event, right? You may come across a patient who has chronic renal failure, you do biopsy, glomeruli are fibrotic, you check out he is not hypertensive, he is not diabetic, maybe previously he developed some degree of glomerular disease and that was not properly diagnosed and may remain asymptomatic. There are many patients who keep on having proteinuria of subnephrotic range for many years. Very mild injury but very prolonged injury, eventually replacing the glomeruli with fibrotic thing. So this concept clear? How these all things interlink with each other? Is that right? So here we'll stop today. In the next lecture, what we will be discussing that in glomerular injury, what are the antigens which stimulate the injury? What are the immune mediated processes? Are they humoral or cell mediated? What are the immunological mechanisms of injury? Then immunological mechanism of injury, how they activate neutrophil, macrophage, complement system, platelet system, and eventually what type of histopathology and immunofluorescence changes come into kidney, like minimal change or membranous glomerulonephritis or membranoproliferative glomerulonephritis or IgA nephropathy or rapidly progressive glomerulonephritis, all these things, and eventually these things, what type of clinical phases they are developing. So we have just discussed injury and clinical phases. We have not discussed why injury occurs, how injury occurs, and what changes in the glomeruli are brought into different type of injury. So that will be done next time. Class dismissed.